All right. Good evening, everyone. My name is Lisa Klasel, and I'm with the Lupus Society of Illinois. We're really excited to have everyone join us tonight for our presentation on lupus and fibromyalgia. Before we get started, I just want to welcome everyone and thank you all for being here. I want to thank tonight's sponsors, GSK and Aurinia, who allow us to have these educational events free to all of you in the lupus community. I also want to just make a couple announcements. We do have upcoming events. Our next event is December 3rd at Rush. It's our annual Rush clinic with LSI. And so that is December 3rd. You can register for that event on our website at lupusil.org. Sorry, it's www.lupusil.org. And there's all sorts of information on that as well. We also are getting ready for the Chicago Marathon 2023. We do have a lupus charity runners team. So if you are interested or know anyone who run, please check out our website. All the information is on there as well. About tonight's presentation, this event is for educational and informational purposes only and serve to benefit our mission. The Lupus Society of Illinois does not provide medical advice. This information should not be substituted or replace expert medical advice. Before making changes to your medical care, consult your qualified healthcare professional familiar with your medical condition and health status. This event is being recorded, like I mentioned before, and we will archive it on the Lupus Society of Illinois' website. So again, we will keep everyone muted just because we want to give respect to the doctor who will be presenting. A little bit about her. So tonight's presentation is by Dr. Alexandra Katz-Smalls. She is currently a practicing rheumatologist at Rheumatology Associates, a leading rheumatology private practice in Chicago, Illinois. She received her bachelor's degree from the University of Pennsylvania and went on to medical school at the University of Illinois. She completed both her internal medicine residency and rheumatology fellowship at the Rush Medical University. Dr. Small is a board-certified rheumatologist. Dr. Small is an associate professor of medicine at Rush University Medical Center. She's extremely passionate about the field and has been her lifelong dream to be a rheumatologist. Her practice focuses on delivering her patients a unique experience of individual attention and compassionate care. In addition for caring for patients, she's also very active in clinical research, publishing numerous articles and abstracts in rheumatology journals. Her interests outside of medicine includes travel, running, and spending time with her family. But this time I'm going to turn over the presentation.
Thank you so much. Let me see.
All right, so
see my screen?
Not yet.
Okay, share screen. Oh, there we go. Okay. Can you see it now?
Yes, we can.
Okay. Okay, thank you so much for having me. I'm super excited to be here. Just a little bit about elaborating on what you said, how it's my lifelong dream to be a rheumatologist, and that's not a joke because my dad is a rheumatologist. He's been a rheumatologist for 40 years, and I've grown up going to his talks, his lupus talks as a little girl. So I'm super honored to be here today. And I actually work with my dad and my husband, who's also a rheumatologist. So it's a field I'm extremely passionate about. I really love it. I love the patients I get to know, and just trying to help people is the main
I'm just trying to listen to her.
Just trying to help people is such a satisfying thing to do on a daily basis. And one of the nice things about rheumatology is you have chronic long-term relationships with patients. So it's not just a one-time hi and goodbye. It's you really get to know the patients and their families and their lives. And that's super important to me. So today we're going to be talking about lupus and fibromyalgia. This is a painting by Frida Kahlo. And I think it pretty well, I don't know if she had fibromyalgia, but I think it pretty well depicts what fibromyalgia feels like. You can see the broken cracks in the back of the, in the ground and all the nails in her and in her broken spine. And it's just, again, I don't know her situation, but it looks like someone to me suffering from chronic pain, which is what fibromyalgia is. And she said, I never painted dreams, I painted my own reality. So first we're going to talk about lupus because obviously it's a lupus society. Let me just, so, oops, no. Let's get back in my presentation. Okay, so lupus is a systemic autoimmune disease that can affect really any organ in the body. And that's one of the things too that makes rheumatology special is, you know, you have your cardiologists, you have your nephrologists who deal with the kidney, you have your pulmonologists who deal with the lungs, and rheumatologists are really systemic people. We see lupus can affect any organ, the skin, the lungs, the eyes, the heart, you know, really anything, the kidneys, obviously. So that's one of the things about lupus. Again, the word in lupus is systemic. It's a systemic illness, and it presents in different people differently. One of the things I'm sure you've all heard about is the ANA test. One of my most common reasons seen for a patient is their primary care doctor checked an ANA and that was positive. So it is like quote unquote a lupus test, but we'll talk more about that. And again, patients present with different clinical features. It can be lupus. One of the crazy things about lupus is it can be very mild, really mild, and patients are totally fine. And then you can see the extreme of that, and you can see really sick people in the hospital, young women, you know, on the verge of death, basically, because they're so sick from their lupus. But I would say that is a rare thing. You know, obviously most people are more in the middle, but, you know, you can get very sick from it, especially if it's not treated. But most people, again, coming to my office are totally fine and living their normal lives. But you can have mild joint and skin involvement to life-threatening kidney, hematologic, or central nervous system involvement. And it's a clinical diagnosis lupus. So it's based on your clinical history, what you see on clinical exam, and labs. And another interesting thing about a rheumatologist, I sometimes tell patients is, sometimes you feel like a little bit of a detective. It's like you have to put together the pieces of a puzzle. Okay, it's this lab with this physical finding, with this symptom that the patient's having, and it's kind of putting it all together to make a puzzle and to make a full picture. So it's not always obvious. Usually it's not obvious the first visit or the second visit. Sometimes, as many of you probably already know, it takes a long time to get to that place. And it's, again, putting together little clues that I was trained to look for to make the diagnosis. Blood testing, serological findings are important. So besides the ANA, there's something called anti-double-stranded DNA and anti-Smith antibodies. Actually, anti-Smith antibodies are the most highly associated with lupus, most specific. So some of the clinical manifestations, so if I just read the big bold words to fatigue and myalgias. Myalgias means muscle pain, and fatigue, obviously we all know what that is. So once you get to know, if you already don't know what fibromyalgia is, there's a lot of overlap between lupus and fibromyalgia. And that's why I think a lot of people get misdiagnosed or, you know, misunderstood. But if you can see why, that fatigue and myalgias are two of the most important things in lupus. And those are two really non-specific things, but you definitely see those in fibromyalgia too. So besides fatigue, fevers, you can see in lupus, weight loss, and the muscle pain, and also I'm going to show you arthralgias. So arthralgias or arthritis. This picture on the side is Gicoud arthropathy, it's called, and it's basically a non-erosive arthritis you see in lupus. It's different. It kind of looks like a rheumatoid arthritis hand, but you can actually, if this patient straightened up or made a full fist, their hands would go turn to the radial side. Right now, their ulnar deviated, meaning they're turning towards the pinky. So it's a non-destructive, or rheumatoid arthritis is destructive. You can't move that hand back, where in lupus you can. This is pretty, you know, you don't see it every day, Gicoud's arthropathy. But the point is you can see it in lupus, and you can also have joint pain is a big thing in lupus. Over 90% of patients with lupus have joint pain as one of the earliest manifestations. Arthritis with inflammation occurs in 65 to 70% of patients. So when we say inflammation, as a rheumatologist, we're trained to look at your joints and see if, you know, sometimes I'll have patients say my joints are swollen, but see if you actually have pain when you move the joint, and is there synovitis or swelling in the joint. Oftentimes you don't see that in lupus. You see it more in rheumatoid arthritis and other inflammatory arthritides, but you can see it in lupus. The arthritis in lupus is moderately painful, usually does, again, not cause erosion, and is rarely deforming. But you can get a deforming arthritis, but that's more if you have concomitant rheumatoid arthritis, which we're going to skip over that. So skin is a big one in lupus. And, you know, I've seen this picture so many times, the woman on the right with the malar rash, obviously the famous lupus butterfly rash. And then below is a guy with discoid lupus. So a malar rash is a photosensitive rash. And this picture on the top, I have a better picture. A malar rash really spares the nasolabial fold. So like right next to the nose, you're not going to see red. So it's oftentimes, not oftentimes, but it can be confused with rosacea, because rosacea can look like that. So sometimes I send people to dermatology, but sometimes it's pretty obvious if a patient's lupus is so active and they have this butterfly rash. You don't have to have the butterfly rash. And that's the thing about lupus. You don't really have to have anything. There's different variations of it. You can just have kidney lupus. You can just have skin lupus. So it is a little bit confusing. You don't have to have all the features of lupus, but these are just some of them, the things we look for. So again, this butterfly rash, it's on the cheeks and the nose, and it appears after you go out in the sun. Discoid lupus, which can be a scarring lupus. And in discoid lupus, you don't have to have systemic lupus. So you can just have skin lupus, just the skin, no involvement of the kidneys, no involvement of the joints. You can have that with just discoid lupus and other kinds of cutaneous lupus. Photosensitivity is a big one we ask patients. And I usually ask patients, if you go out in the sun, do you get a rash, or do you feel sick from the sun? And if you get a rash, does the rash last? You know, if you get a rash and it lasts for a few hours or less than 24 hours, I don't think of that as a real lupus rash. But if you go out in the sun and you get a rash that's not going away, that could be a photosensitive rash. Oftentimes patients develop ulcers in the roof of their mouth. So the hard palate I look at in patients that can be associated with their lupus flares. You can get nasal ulcers too. And then you can get alopecia, which is a fancy word for hair loss. So you can get scarring or non-scarring alopecia. So that's another often common consult I see for patients is their dermatologist referred them because they have this hair loss and they checked an ANA and it's positive. So there's lots of different reasons for alopecia, and lupus is one of them, but there's lots of other ones too. So again, it's putting together a picture, finding these little things and putting it all together to make one diagnosis. So this is a perfect example of a photosensitive rash. I mean, you can see here how her shirt was covering her shoulders, and where she was sun exposed, she got a really bad rash. So that's an extreme example of a photosensitive rash, but you can see how it obviously looks like a really bad sunburn. And here's another example of a malar rash. And you can see again, this one's better showing around her nose, how it's white right there. There's not that red rash right there. So that's sparing the nasolabial folds. And that's really like a sunburn. When you get a sunburn too, it spares right there. This is subacute cutaneous lupus, which is basically just another form, just to say there's a lot of skin lupus or cutaneous lupus forms. And this is a non-scarring widespread rash, subacute cutaneous lupus. And it's a photosensitive rash too. And this is another one that's a little bit interesting just because they call it interarticular dermatitis, but this is another lupus rash. But interestingly, it's not on the joints, it's in between the joints. So if you look around the cuticles, they can be really red and raggedy. And oftentimes we look with a dermatoscope at the cuticles to look for capillary fold changes. And then around the joints, they're really red. So we have another disease we see, polymyositis, where they actually get red on the joints, where lupus, it's not on the joints. And here's another malar rash, again, sparing the nasolabial fold. And here's an example, they call it bullous lesions, but basically on the hard palate, some lesions you can see at the top that can be associated with lupus activity. So cardiac involvement lupus, again, lupus can involve any organ. The most common thing I would say I see with lupus is pericarditis. But you can have really anything. It can affect the myocardium. It can affect the conduction system, the coronary arteries. Another big one that's kind of, I wouldn't say overlooked, but patients with any inflammatory disease like lupus or rheumatoid arthritis are increased risk for coronary artery disease. So heart attacks and strokes because of all the inflammation in your body. So once you're diagnosed with that, I think we have to be a little more vigilant with screening and family history for that and statins and things like that. But you are at an increased risk of coronary artery disease. There's something called Lehmann-Sachs endocarditis, which is a sterile endocarditis. Endocarditis is when you get little lesions on your valves in the heart. And in lupus, you can get that, but it's not an infective endocarditis. It's not from an infection. It's from lupus. Then you can get myocarditis, which you can get pretty sick with myocarditis, inflammation of the myocardium. And then another big one is you can get neonatal lupus, or a baby can get neonatal lupus. If a woman has an SSA antibody, they can pass it to the baby, and babies can have congenital heart block. You know, there's always a lot to worry about in life, right? Vascular abnormalities. So this is another big one, Raynaud's phenomenon. So you can have primary Raynaud's when you don't have lupus. Like, for example, I have Raynaud's. I go out in the Chicago winter and I go to the garage and my fingertips are white, but I don't have lupus. And so you can have it and not have lupus or another autoimmune disease, but it can be seen in lupus and scleroderma and other rheumatologic diseases. So again, it can be primary, not related to a rheumatologic disease, or you can have it secondary to a rheumatologic disease. But basically its color changes the tips of your fingers in the cold. So it has to be associated with cold, and your fingertips turn white and then they can turn blue or red. And sometimes it can be a little painful, but the main thing is just to keep warm. You can also get vasculitis, which is inflammation of the blood vessels. So that can occur in lupus, and it can involve any size blood vessels, the small, medium, or large blood vessels. And another big thing in lupus we see is something called antiphospholipid syndrome, which is a clotting disorder that can be associated with lupus. Usually it is with lupus, but you can also just have it not associated with lupus. And patients get blood clots like DVTs, pulmonary embolisms. They have more risk for miscarriages. They can have strokes. So if I have a lupus patient, we're always checking in any rheumatologist to make sure you don't have these antiphospholipids, because if you need to be on a blood thinner, we need to know if you're at higher risk for a clot. This is just an example of vasculitis in a lupus patient on their fingers. And you get these lesions that are hard to heal. And this is an extreme example, obviously not seen every day, but where you actually get digital gangrene of the hands, and the digits will actually auto amputate. The tips of the fingers will just fall off. And obviously this is an extreme example. And, you know, in medicine, you see extreme things, and this is not what you see on a daily basis, but it can happen. But that's with terrible Raynaud's and terrible vasculitis. I mean, you have no blood flow going to the tips of your fingers with that. So kidney involvement is a really big one for lupus. There's something called lupus nephritis, and that's, you can have no other manifestations of lupus and just have kidney lupus, and therefore you have systemic lupus. So lupus nephritis occurs in about 50% of patients, and that's one that's a silent thing. So that's why in all lupus patients, you come to see the rheumatologist, and we check your urine for protein and blood, and we check your labs, because there are a few silent things that you actually wouldn't feel unless it got so bad. You know, it's not like it's a rash that you notice a rash on you. This you would be asymptomatic for, unless your kidney function got so bad. So that's why we check to make sure you don't have any protein in the urine, any blood in the urine, and check your serologic, your blood work too, but also your urine to make sure. And this is way, you know, you don't need to know this obviously, but there's these different classes of lupus nephritis, and some are worse than others. And at the end, you can get scarring and then actually need dialysis or a transplant. So that's why these patients need to be treated, and treated aggressively, because nobody wants to be on dialysis, and it happens more than you think. So that's just why you need to be monitored by a rheumatologist. So GI involvement. GI involvement is probably the least of what I see with lupus. I think I read somewhere it was like 70% of patients with lupus, but they have GI involvement, but that was talking about mostly medication side effects. You can get pancreatitis, you can get hepatitis, you can get this protein losing enteropathy, pseudo-obstruction, esophagitis, ischemia, peritonitis, but basically that's not our first go-to in lupus. GI involvement, I've had a couple patients as that was their presenting symptom, was a GI involvement that was in the hospital, but it's pretty unusual for that to be your first presenting symptom. Usually, again, it's joint pain and rashes. And pulmonary is actually pretty common. You can get something called interstitial lung disease, something called pulmonary hypertension, where the pulmonary arteries pressure is high. A weird name of it's just associated with lupus. It's called shrinking lung syndrome. You can get alveolar hemorrhage. It basically just means you have a bleed in your lungs. And then a big one too, we see a lot in lupus patients, is because they're on immunosuppressants, they can get pneumonia or they can get infection. So it's always important to distinguish. You have a patient in the hospital, actually when you get a chest x-ray, sometimes you can't tell if the infiltrates on a chest x-ray are pneumonia or they blood. So they have to go and bronch you and see, is there infection growing there? Is that blood? So the big thing in when hospital patients and sick patients is making sure that what's going on is not an infection, because if you start treating them for lupus, you're going to be suppressing their immune system more, and that can make the infection worse. But that's always a big conundrum of infection versus active lupus. And oftentimes they go together, which is hard because lupus needs to be treated with immunosuppressants. And again, you can get blood clots, like I talked about in the lungs with antiphospholipid syndrome. The lupus anticoagulant is just one of the antiphospholipid antibodies. So another big one we see all the time is, again, these are just clues. You're looking, you see a patient, you're looking for clues of activity. And one big one is in hematologic abnormalities. So in your blood count. So a lot of lupus patients have a low white count, and it's usually lymphopenia. So these are big words. Leukopenia means low white count. Lymphopenia means low lymphocytes. So the white blood cells have different kinds. There's different kinds of white blood cells, neutrophils, lymphocytes. There's a bunch of different kinds of white blood cells. And when you're lymphopenic, you're low on a certain type of white blood cell. And you can see that a lot with lupus patients. Some of the medicines we use also cause low white count or leukopenia. So it's always hard to sometimes distinguish, is this medicine making the leukopenia worse, or is this just their active lupus? Another very common thing you see in lupus is thrombocytopenia, which is a fancy word for low platelets. So the CBC or blood counts are really important to look at in all lupus patients. And then the third bloodline, you see a lot of anemia in lupus, and there's different kinds of anemia you can see in lupus. So there's something called, I mean, you could just see plain old iron deficiency anemia, which you can see in anybody. You could see anemia of chronic disease, which is basically anybody who's got an active chronic disease. Like if you have kidney disease and it wasn't related to lupus, you could have anemia. So if you have an active chronic disease, you can have anemia. And then there's something that's more rare called hemolytic anemia, where the red blood cells are actually shearing, and it's hemolytic, it's hemolyzing. So, you know, again, all things that why we have lupus patients come back and we follow them closely, because sometimes things are not as obvious on the surface, and you need to be following people, you know, following their labs, not just their symptoms. And then eye is another one. Again, any organ in lupus, I don't think of the eye as one of the biggest ones, but again, it definitely can be affected in lupus. You can have really dry eyes. You can get secondary Sjogren's syndrome, which is another thing that we treat. And Sjogren's syndrome is basically dry eyes and dry mouth. And I'm talking about really dry, where you can't make tears. You feel this gritty sensation in your eye, like a sandy sensation. Plaque, one of the medicines used for lupus, can also cause lupus retinopathy. So that's why we have patients go to the ophthalmologist to make sure they look in the back of the eye. But you can get other things like optic neuropathy, which you can see in MS, scleritis, episcleritis, that's inflammation when the eye is really red. Uveitis, same thing, the eye gets really red and painful. Again, just the fact that lupus is a systemic illness. So we've talked about the eye, GI system, lungs, heart, kidneys, skin. It can affect any organ. And then last, but definitely not least, is neuropsychiatric lupus, which is, again, not something you see every day, but patients can present with brain involvement in the lupus, CNS involvement. So you can have a patient come in with seizures. You can have a patient have a stroke, a young female have a stroke, and she's 20 something. People can get really delirious, confused. They can have psychosis, you know, see things that aren't there, really severe depression. And the way you really be able to diagnose this, there's a couple ways, but one is you need an MRI of the brain. And the other is a spinal tap. So they take the fluid, they take the fluid and they look if there's inflammatory cells, but you have to also, again, put the picture together. If this patient has active lupus, and then you see inflammatory cells in the spinal fluid and changes on the MRI, you might consider neuropsychiatric lupus. But, you know, again, those patients are usually pretty sick and in the hospital. So the labs we talked about, we're going to be checking CBCs. We're going to be checking urine for blood, hematuria, proteinuria, blood and protein in the urine. We definitely need to check your kidney function, because when it involves the kidney, your creatinine goes up, your kidney function test goes up. Sometimes you check an SPEP. This is probably way too much information, but patients with lupus have so much inflammation. They have something called hypergammaglobulinemia. So they have all this inflammation. They're making all these antibodies, but that's, you know, it's just basically you need to be monitored and things need to be followed. And these are some of the more tests, antiphospholipids, like I talked about lupus anticoagulant, and there's other ones. We check anticardiolipin and beta-2 glycoprotein. I mean, these are all just really fancy sounding names. I'm sure a lot of you have heard of complement levels. So in lupus, C3 and C4 particularly can go down. They don't have to for all lupus patients, but they can be a sign of disease activity. Sed rate and CRP are rheumatologists' favorite tests. So they're totally non-specific, but they're a marker of inflammation. So I always tell patients they can be elevated in autoimmune disease, they can be elevated in cancer, they can be elevated in infection, but they're just kind of a good indication that maybe something's going on. We look at the urine and the protein in the urine, and then some of the other lupus tests, like I mentioned, are double-stranded DNA, Smith antibodies. So they say anti-double-stranded DNA and Smith antibodies are approximately 70 to 30% of patients with lupus. Some more other ones are SSA and SSB antibodies. RNP antibodies go along with a mixed connective tissue disease, and anti-ribosomal P antibodies go along with CNS lupus. But I don't check those unless I have a high suspicion for CNS lupus. So again, how is the diagnosis made? It's a clinical diagnosis. There are criteria, which I'm just going to briefly show you. There's an ACR 1997 criteria, there's a SLIC criteria, and there's a newer EULAR criteria. But those are more for research purposes. Those are so you can get patients enrolled into a study and say, okay, this person has lupus. But do we use those in our office on a daily basis? No, it's really just after you've done something, just it's almost like again, just putting together the pieces. And if you have enough pieces together of the puzzle and you can make out the picture, it's making the diagnosis. And sometimes rheumatologists don't always agree on the diagnosis of lupus. I tend to be more strict on it. I want to make sure. I don't want to call someone lupus unless I'm sure, because once you go down that road, everything gets associated with lupus. If you go in for chest pain, they say, could it be your lupus? If you have a headache, could it be your lupus? So I'm trying to be very careful before I give out the diagnosis, just again, because it follows you for the rest of your life. It's not something to be taken lightly. Any medical student, any resident, you go to the ER and they see lupus in your history and they're going to start to worry about the lupus. So not that there's anything wrong with that. I just want to make sure that I'm 100% sure that the patient has lupus before I give him that name. And I know you all know the ANA antibodies, anti-nuclear antibodies. So the nucleus of the cell lights up. There's different ways you can do it, immunofluorescence being the best way to test it. And we look at the titer. So it goes by, depends on the, where you're at. It could be positive 1 to 40, but then certain centers like, I think UIC doesn't call positive until it's 1 to 160. So the titer keeps going up. And I would say the titer doesn't go along with disease activity, but the higher the titer, the more meaningful the ANA is to me. If your ANA is 1 to 80, it's different than someone whose ANA is 1 to 1280. I have seen sick lupus patients with an ANA 1 to 80, but for the most part, the higher the titer, the more meaningful the test is, the more positive the test is. And again, this is just a list of some of the antibodies. Double-stranded DNA. Histone is one that goes along with drug-induced lupus. Smith, RNP, SSA, and SSB. So these are some of the criteria. This is the 1997 criteria where you need, well, now see, I forget because I never use the criteria. 4 of 11 you need for the criteria for the 1997 criteria. But again, for research purposes, and this is an old one from 1997, but I do think it actually is my favorite one, and it's the easiest one to use. The other ones get so complicated, like the SLIC is complicated. And here's the EULAR, which is super complicated. And for EULAR, one thing is you can't even enter the criteria unless you have an ANA above 1 to 80. And it's adding up these points, but who's going to remember these points unless you're sitting with this form in front of you? Again, it's for research purposes. If I was going to pick one to use, I like the 1997 criteria, but I don't use it myself. So what are the medications for lupus? NSAIDs, anti-inflammatories, Plaquenil or hydroxychloroquine is probably the most famous one. And then prednisone, obviously, for flares. Immunosuppressants. So besides Plaquenil, then you start moving up the chain. So azathioprine or Imuran is one we use a lot. Mycophenolate, or it's also called Cellcept. Methotrexate, which is one we use for rheumatoid arthritis a lot, is also used in lupus. Cyclosporin, And then some of the biologics like Benlysta, Rituxan, and Safnello are newer ones. Rituxan's older, but Benlysta and Safnello are new. And again, if someone's very controlled, they're usually just on Plaquenil. But once you start having different manifestations of lupus, we start adding different things. Usually, first, I would say it's between azathioprine, mycophenolate, or methotrexate as the second line agent besides prednisone. And then now Benlysta is moving up the ladder too. Rituximab's good, but rituximab's a heavy duty immunosuppressant. So, but usually all patients should be, unless they can't tolerate Plaquenil or they have issues with their eyes, on Plaquenil, and then we add other agents. So another Frida Kahlo painting, again, just depicting her, I think it was her, she was painting self-portrait, so her struggle, if you see the blood gushing out of her back and her misery laying on a hospital bed. So fibromyalgia is something we see so much on a daily basis. Most of my research is in fibromyalgia just because you see it so much. So these are some forms we hand out at our office. And I want to be clear that this is not the typical fibromyalgia patient. This is just an extreme version of it, just to show you, again, this is an extreme version of someone. I mean, you can make the diagnosis just looking at this sheet because they filled in the whole person. But fibromyalgia is not always like that. It's not always, I hurt from the tip of my head to my tippy toes. It's usually actually not like that, but it can be. And the other thing is that patients have really severe pain. It's not like, oh, if I were to rate my pain, it's like a 1 or 2. It's like patients are 5, 6, 7, 8, 9, 10. And they're sitting and talking to you and you're, 9 out of 10 pain. And is their pain real? Their pain is 100% real. It is not made up pain. They are in 9 out of 10 pain. It's just crazy that they're able to function at that level of pain, and it is not made up. And it is, I mean, I can't tell you how many people come to my office with similar stories and, they've, gotten the runaround from different doctors and they feel, they get test after test and every test is normal and people are super frustrated. It is real. It is real. Fibromyalgia is real. It is not made up. It's just, we don't really know the cause of it. And that's the problem. We don't really know how to treat it that well yet. Although my dad, the famous rheumatologist, thinks he's got the cure. So, so that's why it's frustrating, probably mostly for patients, for doctors too. But it is a real pain patients have. Here's another example of, just these random spots on this person, their pelvis, their calf, their knees, half of their face hurts, their whole spine. Again, I have plenty of fibromyalgia patients that come and just circle their joints. It doesn't have to be like this. I'm just showing you the examples. But if you look at the first question, how severe is your pain over the past week? 10. I mean, this person is in 10 out of 10 pain. Another example, there's patients pain is an 8, their pain. So the history of fibromyalgia, a little bit about it. Sir William Gowers coined the term fibrositis, and itis, if you don't know, it means inflammation, in 1904. Fibromyalgia is a more recent term. They took away the itis because they did muscle biopsies and they realized that there wasn't actually inflammation. I just want to make sure I have enough time. Okay, 10 minutes, I think. There wasn't actually inflammation in the muscles. So Smith and Moldavsky in 1970 described tender points in fibromyalgia, and oftentimes I'll check those points. They don't have anything to do with the criteria. So in the 1990s published criteria for the classification of fibromyalgia, but then they redid the criteria and they took away the tender points. And actually my dad was involved in that and taking away the tender points as part of the criteria. Like I said, I do check them, but they don't really, make a difference in my mind. If they're positive, they're positive. So what is fibromyalgia? It is chronic widespread pain for more than 3 months, not explained by something else. So these patients have severe pain. Again, as I mentioned, it's 5, 6, 7, 8, 9, 10. It's most days of their life. It doesn't have to be every day. And it's severe. They have trouble with sleep. They have something we call fibrofog, which I'll get into briefly, where they have memory and concentration problems. But if you were to narrow it down, it's pain, trouble with sleep, and this fogginess. And they also have heightened sensitivity to things, allodynia and hyperalgesia. It affects about 2 to 5% of the US population. It's more common in women than men. Millions. So this estimate, but this is from the 1990s, I think, is over 6 million Americans have fibromyalgia. I would argue it's much higher than that. So this says 10 to 12% of the US population. Again, the pain intensity usually exceeds 5. They can have, like I said, localized symptoms. So they can have, if they come to my office, they may just come for knee pain, but when you start to ask them, does your neck hurt? Does your back hurt? And they say, oh yeah, actually I have really terrible neck pain and I have terrible back pain. And they start to, things start to come out. Again, the sleep disturbance, significant fatigue, the tender points, which aren't part of the criteria, and the fibro fog. So this is the old criteria, and those are just the little circles are the old tender points that used to be part of the criteria, but they're no longer part of the criteria. And this is just a shout out to my dad, who is not on the call, but his name's Robert Katz. There he is. That's my dad, and he was involved in changing the criteria, the ACR criteria. This is a form I sometimes give patients. Again, for fibromyalgia, I never use diagnostic criteria to make the diagnosis. It's not to make the diagnosis a diagnostic criteria, even though it has the word diagnostic in it. So we basically check, the parts of you that hurt, and then you get points for fatigue, trouble thinking or remembering, waking up tired, abdominal pain, depression, and headache. And if you have 12 out of the 31 points, you meet the criteria for the diagnosis of fibromyalgia. So a lot of patients that I see have migraines, they have irritable bowel. I have a lot of paresthesia. So paresthesia is numbness and tingling. People come in, they have unexplained numbness and tingling in their hands and their feet. If you rule out a nerve involvement like an ulnar neuropathy, sometimes it could be from the fibromyalgia. Pelvic floor pain, something called interstitial cystitis, where people get like frequent UTI symptoms, chronic fatigue syndrome, chest wall pain, or the doctor refers costochondritis. A lot of people without fibromyalgia get costochondritis, but a lot of fibromyalgia patients have chest pain. They end up going to a cardiologist. They get a whole cardiac workup because nobody wants to miss chest pain, and they'll end up telling them it's chest wall pain and jaw pain, TMJ. So usually, not with all patients, but usually, like I said, the typical patient is frustrated because they've had test after test. They've had blood tests, they've had x-rays, they've had EMGs, they've had MRIs, they've had CTs, they've had every test you can imagine, everything comes up negative. Sometimes people have positive ANAs or mildly elevated inflammatory markers, but for the most part, it's very frustrating because why do I feel so badly? Why am I not able to do my best at my job? Why am I struggling every day of my life? And then every test comes back negative. We can just skip this. So the other thing is that it's often not picked up by doctors, and many people think it's a wastebasket diagnosis, not worth taking seriously. But it is a real diagnosis. And again, these people with fibromyalgia, I see them every single day and they're struggling. Some are able to cope with it well. And I think, understanding you have it is the first step in the game. And certain patients I have learn what works for them. I have one patient that loves aqua therapy, another one that stretches every day, other people that they need medication. So you have to learn what works for you. But I think accepting the diagnosis and having a doctor that understands that this is not, it's an invisible disease, but it's not made up. It's not in your head. It's not a psychiatric thing. It is a real illness. So again, the central concern for patients with fibromyalgia is disbelief from their physicians, not only from their physicians, but from their family members. I mean, I've had a lot of family members who, are trying to be supportive of their spouse, but they're frustrated. They're frustrated that my wife or husband's always in pain, or their daughter or son. So, it can be frustrating on all sides, but it's not, again, as it says there, in your head. It is not made up. It is not someone looking for attention. It is a real thing. And one day, I really, truly believe we will get to the bottom of it. That'd be pretty cool if it's in my lifetime. So it takes 5 to 7 years for most patients to first get the diagnosis. They go from doctor to doctor. There's no real gold standard test. Again, if you're not really looking for it, a lot of patients I have go to surgeons and they have a shoulder surgery, arthroscopy, and they have a knee arthroscopy, and they have a knee replacement, and they have this and they have that. And it's because if you're not really looking for it, sometimes you can miss it. It's right under your nose. But if you're not trained to look for it, especially with surgeons, because they're not, that's not their interest. That's not what they're looking for. Someone's coming to them with a problem, whether it's pain in a joint. So you really have to look for it and know what you're looking for. And then sometimes it's hard to give patients the diagnosis. A lot of times I don't think people want the diagnosis, and that presents a hard problem between a patient and the doctor, because you want to feel like you can tell the patient, you know, what you're really thinking, but you don't want to upset anybody at the same time. I got to speed up, I think, so I'm going to go quickly. Fibrofog, I think I only have 4 minutes, right? Fibrofog, again, is what I mentioned, is this fogginess. We've done studies where it shows that patients with fibromyalgia have delayed processing speed. So you can see here, fibromyalgia syndrome, they answer the questions in 620 milliseconds, where the control answered the question in 417 milliseconds. So a lot of people feel, as we've said in our studies, a beat behind. They'll be sitting in a work meeting and they're like, everyone else seems to know what's going on. It's kind of like ADHD. Everyone else seems to know what's going on and they're a beat behind. It takes you a minute. You're kind of, you know, in la-la land, and then you get back in it. La-la land, meaning you're just in this fog. Lyrica, some of the FDA approved medications for fibromyalgia are Lyrica, Cymbalta. They're not honestly my favorites. It's on a case-by-case basis I use them, but amitriptyline's one we use a lot. These are different antidepressants used for fibromyalgia. Cymbalta is the one that has FDA approval, and then Savella at the bottom. This just shows that opioids are not helpful in fibromyalgia. So, you know, I wasn't practicing in the 80s and 90s, but I think that it used to be treated a lot with opioids, and now it's not. And it's just because it was shown to actually not be helpful in the long run for patients with fibromyalgia. So if you look at this one, it says opioid improvement in pain. No, there was no improvement in pain with opioids. And this is a slide just showing that patients with fibromyalgia this is our study, get more surgery. So patients with fibromyalgia, 26% had a cholecystectomy, where non-fibromyalgia patients, nine patients or 12% had a cholecystectomy. A hysterectomy, 48% of this group of patients had hysterectomy, fibromyalgia patients, were 24 or 32% of non-fibromyalgia patients. So again, these patients are in pain and they're looking, oh, if I have pelvic pain, maybe if I get my, you know, uterus out, I'll stop having pelvic pain. And I'm not saying that's always the issue. You may have a real issue that the uterus does need to come out, but patients are in true pain and they're looking for relief. So our goal of treatment is to get people to sleep through the night. I mean, that's my number one thing, is having them sleep through the night. If you don't sleep well, you're going to be in pain no matter what, with or without the diagnosis of fibromyalgia. Medications are often used. Our big thing now is using muscle relaxants. Our research has showed in our practice that actually we think, and I'm not going to get into it because I don't know how much time I have, but a long and short of it is that we think there's a big muscular component to fibromyalgia, much more than has been looked at before. The current theory behind fibromyalgia is the central sensitization. So basically that the patient is misinterpreting pain when pain isn't there. So let me just pull up this graph. So there's a study done that had patients with fibromyalgia go in a functional MRI machine, and you can see the brain MRI on the left, and a functional fMRI machine, different centers of the brain light up. So you can see the triangle, the fibromyalgia, it says fibromyalgia and it's a bluish triangle. So those patients, they had their thumbnail pushed, and you push on the patients with fibromyalgia's thumbnail and their brain centers in the fMRI are lighting up. So pushing on a fibromyalgia patient's thumbnail, the fibromyalgia patient's brain is saying pain, pain, pain. Whereas the controls, the yellow ones, you need to push much harder on the controls for their pain centers to light up. So that's why the current theory in the literature is that it's a central processing disorder, meaning the wires are mixed up basically, and you're interpreting pain and a threat to your system when there's really not pain there. Our research and our practice deals more with muscle involvement. We think the muscles are tight, and we test patients' muscle pressure. And we found that patients with fibromyalgia have 3 times higher muscle pressure. So we're really working on this muscle pressure thing because we think that there's a big, a peripheral component. Again, it's not just the brain, there's muscle problems too that are causing pain and not muscle inflammation like it used to be called fibrositis, not inflammation, maybe hypoxia, we're not sure, which means the muscles aren't getting a blood flow. And then this is just, I'm going to end, I think we have to, so this is just to show that patients with fibromyalgia have hypersensitivity. Oh, and then okay, just to end it, because I know we have to go, the main thing is putting them together. Lupus and fibromyalgia, you can have both. You can have just lupus, you can have just fibromyalgia, you can have lupus and fibromyalgia. Patients with rheumatic diseases like lupus, like rheumatoid arthritis, are more likely to have fibromyalgia. According to this one study, they're 22% more likely than patients with rheumatic disease to have fibromyalgia. So it is complicated, and that's the job of your doctor to differentiate. If your lupus is active, is it the lupus? Is it the fibromyalgia? And again, you can have both. You can have, I think fibromyalgia, sometimes people are misdiagnosed with lupus. You know, it just depends on the situation, but you can have both. And sometimes it can confuse the disease activity in lupus because some of the things are myalgias, muscle pain, arthralgias, joint pain, fatigue, things that are common in lupus and fibromyalgia. So sometimes it can be misleading in disease activity of lupus if you have concomitant fibromyalgia. And again, I can end there, but I really thank you for having me. And I'm just so thrilled to be able to be doing this with my life. So thank you. I can't even see anyone.
All right. Well, thank you so much, Dr. Small. That was a lot of information. Very
I know
good.
A lot.
For someone like me, I don't really know much about fibromyalgia, so that was a great overview and explanation. We will open it up for Q&A. So if anyone has any questions, if you could chat them to me, we will start going over some of them. And there's already a couple in there. We will start with Mari. She said, what is the difference between cutaneous and discoid?
So cutaneous lupus, cutaneous means skin lupus. So there's different kinds of skin lupus, one being a malar rash, one being discoid, the other one, you know, there's a bunch, but subacute cutaneous lupus, like I meant. So cutaneous just means skin. So discoid is a kind of cutaneous lupus. And discoid, you know, again, sometimes I don't know how much to include, but discoid does not necessarily have to go along with systemic lupus.
All right. And then Karen has a question. Are swallowing issues and dry mouth associated with lupus or Sjogren's?
So I think of it as secondary Sjogren's. When secondary meaning you have a rheumatic disease and then you secondarily have Sjogren's with the antibodies, the SSA and SSB antibodies. And that's a question I often ask patients, because if you ask a patient, do they have dry mouth? A lot of people say yes. So I say, can you eat a piece of bread without having to drink water to get it down? So you can have esophageal issues in lupus, but the really dry mouth and the trouble swallowing because you're so dry is more likely secondary Sjogren's.
All right. A question from MD. Is fibromyalgia an autoimmune disease?
It is not an autoimmune disease. It's rheumatologists see it and we see autoimmune diseases, but fibromyalgia is not autoimmune. That's a good question.
Yeah, that is a good one. Keep chatting some questions away. Some other ones that have come through. I know you mentioned that lupus and fibromyalgia, sometimes, people can have both or one or the other. Do you usually see people diagnosed like years apart, or is it something like at the same time?
I would say more, it totally depends, but a lot of times people come in with the diagnosis of lupus or again, rheumatoid arthritis, and they're not doing better on their current therapy. And then you have to kind of wonder, is there an underlying diagnosis of fibromyalgia also? So I would say, if I had to say, it just depends on the patient, but more often than not, the lupus diagnosis can come first because it can be more obvious. And then the fibromyalgia is sometimes harder to pick up.
And then you would treat them with the same medication, or is that?
So that's the hard part. You have to differentiate if their lupus is active. If their lupus is active, you're going to treat the lupus. If it's the lupus and the fibromyalgia, then you want to treat the lupus and the fibromyalgia. But I think they're never going to be completely better with just lupus treatment if they have fibromyalgia that's active too.
All right. Patricia asks, if you have arthritis of the hands and wrist along with lupus and fibromyalgia, what type of treatment would you recommend? That's
something you really have to see your doctor for, because it's something that needs to be seen in person. Do you have, I used the word before, synovitis? Do you have swelling in the joints? Do you have morning stiffness? It needs to be differentiated by a rheumatologist, most likely, because, rheumatoid arthritis is very common in the wrists and the hands. So is osteoarthritis. So it needs to be, it could be fibromyalgia too. That's why it needs to be, that's something that you can't do a televisit for. It needs to be physically seen by a rheumatologist to look at someone's joints.
All right.
And one last thing, you
Oh.
could always get ultrasound or MRI of the hand, which can show if the doctor can't figure it out. Sometimes I do an MRI just because it can show inflammation that I can't see on exam.
All right. Is there any more questions? Nope. One more. Okay. Patricia said thank you.
Thank you. Thanks so much.
Debbie Lynch said thank you, Dr. Small. I think you know her, right? Debbie?
Yes, hi.
All right. Anything else?
No, no, just thanks for having me. I'm thrilled to help in any way I can. So
Yeah, no, we really appreciate it. And especially this is, like I said, someone like me who works in the lupus community, we don't really hear much about fibromyalgia. So we really do thank you. Great job, as MD just wrote. But we do, again, want to thank you for your time and all your knowledge for tonight. We also, again, want to thank our sponsors, GSK and Aurinia, for helping us put events on like this that are free of charge to the lupus community. Again, we do have our next event is in person. So anyone that lives in Chicago, we would like to see you at our annual Rush Lupus Clinic and LSI educational event. That's December 3rd. It includes lunch. It's a full day of education. So that'll be knowledgeable, fun, and it'll be nice to like see everyone. So we hope to see you then. And again, thank you so much, everyone. We will archive this on our website. So if you missed something or want to go back and review a slide or have any questions, that will be up soon. And again, anyone can get a hold of me at lisa@lupusil.org. So thank you again, everyone, and have a great night.
Thank you.